Thanks very much, and thanks to the organizers for inviting me, and thank you for attending this morning. So yeah, I'm happy to talk to you about my challenge was to talk about what's next for hepatitis C, and in my view, that's understood best in the context of what we already have. And so I'm going to begin with a bit of an overview of what we have, and then fit in to that what is coming next. Okay, so what we have, what we've already done with what we have, then what we need, and a little bit about what's coming next. Well, first of all, with hepatitis C, we celebrate, at least from a therapeutic point of view, the incredible innovations that have come and in part been recognized with the Nobel Prize for development of treatments that, there we go, that are using pills that you can take for 8 to 12 weeks, cure this chronic viral infection. So for the first time, we're able to shift the paradigm from using interferon that was effective in at most half of people and caused everyone to feel sick, to a paradigm where we give people pills that everyone does great with and cure somewhere in the neighborhood of 98% of the people that take them. So a range of oral therapies that are curative that work in nearly everyone that gets them. So this is the amazing innovation and sort of what we celebrate the most about hepatitis C. In addition, those cures have been received by somewhere and around 15 million people around the world, and so far about 15 million people have been cured. So that's amazing on the one hand, right? On the other hand, it's interesting that there's about 50 million people more than 10 years after the discovery of these who still haven't been cured. And the rate of people who are being cured is just about the same as the rate of people being newly infected. Okay, so at a population level, we're sort of in this interesting place where there's been an amazing innovation, one that is curative, one that it has incredible capability of improving human health, but one that has only reached a small population of those that need. And so that's a bit of the dilemma and a little bit of the context that we currently stay in. And I'll just show you a little bit about that with a couple personal examples, and then we'll talk about what could be done. So this is this is a cohort of injection drug users in Baltimore. We've been monitoring these people since 1988, actually, in the early 1990s. And because they're injection drug users, they have very high rates of bloodborne infections like HIV and hepatitis C. Hepatitis C is nearly uniformly present in the cohort. So we've been monitoring their hepatitis C, and since 2006, measuring their liver disease very carefully using elastography. Every time they come in, we check how much liver disease they're in. But note that this is a community-based cohort. No treatment is being delivered. So it's really asking the question, in the population in Baltimore, what's the net effect of all of the factors, including treatments, on diseases in this cohort? So there's two axes to pay attention. The y-axis will show you, the y1 axis shows you the proportion of viremia. So that's if someone comes into clinic, do they have hepatitis C virus in their blood that day, which was fixed at 100% by the way that we did this study, looking at those that were eligible to be cured in 2006. So notice that going through time, in the period of time when we had interferon, almost no one is cured. Sorry, it's hard to aim this guy, but I'll do my best. It's that top line, which is right up there. Almost no one is cured. Then the DAAs come out and look at the line coming down, sharply coming down. But if I went out another 3 or 4 years, it would plateau, so that about a third of individuals have never received this curative treatment. They're in the same community as the ones that have. They have the same virus as the ones that have. And yet the curative treatment hasn't reached that part of the population. If you look at the Y2 axis, that's a proportion who have cirrhosis. And you can see that it also comes down, but then if I were to continue this out, remains plateaued. So an incredible innovation that has reached some, but not all individuals, had enormous impact in those in whom it's been received, but no impact in those in whom it hasn't. An even more extreme example comes from this cohort in India. So this is a very, very high-risk drug use cohort that's been described for HIV. In fact, the HIV incidence in this cohort was as high as 20% per year. So it's the highest I'm aware of anywhere. Very, very high incidence of bloodborne infections, very, very high risks of all the comorbidities of injection drug use. And so in this cohort, there was an attempt to stratify based on risk and provide very supportive care and treatment for hepatitis C. So we're taking the highest risk group, the most difficult to treat, and we're asking how well can these curative treatments work in this setting. And even in the highest risk group, even with intense supportive, the most intense supportive treatment support, only about 50% were cured. So not 98% like we generally think of for these treatments, but only 50% with the most support we could give. So with hepatitis C, it's a bit of a story of incredible success, incredible potential to cure everyone, and yet at a population level, a different experience. We've had a different experience. So if you step back and say, okay, well, those are a couple of examples, what's going on worldwide, it's kind of this same story, in that if you look at the percent of people who have been diagnosed and then treated in different regions of the world, overall, it's still only about a fifth of persons with hepatitis C who exist in the world have had their infection diagnosed, and even, of course, a smaller percentage have been treated and cured. So the problem is not one of innovation with developing these compounds, but rather how to, at the implementation level, diffuse these curative treatments into the populations, the reservoirs that exist. This is sort of a pharmacology meeting, so if you think about it from a sort of pharmacology point of view, it's like the PK of these medications is not great. It doesn't, their bioavailability, they don't reach at least 80% of the tissues, if you will, where the infection continues to reside. So that's my background. That's my major point. To me, at a population level, what we know is that we have compounds that can be incredibly therapeutic. But if you're an epidemiologist, if you're interested in public health, we have a very different view, which is that, okay, these sort of work in vitro, if you will, but when you look at the whole organism, the whole world, they're not very effective because they're not reaching all of the persons at risk. So it's a bit of then an implementation challenge, and one in which how can we come up with new tools when we look to the future of hepatitis C? How can we solve these problems? These are the big challenges that remain. So what we need has to be understood in terms of what we have and what we've already done with what we have. And so I'm going to show you There's a bit of what's coming and a bit of what's hoped for. Okay, so what's coming is that there are some medications that are cousins or derivatives of the existing curative therapies. And so that's exciting. It's exciting because the more alternatives, the more choices we have, perhaps the lower the price will be, and the more chances to cure individuals. But it's not likely that, so this is a presentation that was shown just a couple of months ago here in Amsterdam at the EASL meeting, describing the very, very high success, so the SVR, the cure rates of individuals who receive these oral treatments that are cousins of sofosbuvir. So it's a nucleotide analog that inhibits the polymerase of hepatitis C, and then another NS5 acting agent that's a cousin of ladipasvir or of alpadisvir. This combination achieves the same sort of success, the same sort of sustained virologic response, the same cure rates, both in persons without and with cirrhosis, as we'd expect with existing pangenotypic oral treatments taken for 12 weeks. So again, very, very high success rates, terrific. It's in phase 3 now, and this is what is coming next. So the answer to your question of what's coming next is here. The challenge is imagining how this will transform what we already have and solve the problem of what we need. And so I'm going to also show another possible innovation that could be coming down the pipe for hepatitis C. And that's this, the idea of taking these oral medications and formulating them into long-acting treatments and potentially providing a one-shot cure for hepatitis C. So now we're asking, okay, can we, instead of giving people pills, give them an injection and be done with it? Don't have to worry about adherence, don't have to worry about whether or not they show up to a pharmacy to get their medications. We'll overcome all of those impediments that are constraining development and perhaps have a little bit more impact on the availability at the population level of these curative treatments. So this program takes advantage of the pangenotypic nature of existing therapies, in particular glicapavir and probentasvir, and their potency, the fact that they are curative at with as little as 6 weeks of oral therapy, and their extremely high efficacy in persons who actually receive them. So very high real-world efficacy, as well as some studies that have been done by and led by some of the people who are here and or regularly attend this meeting, showing high interest in these kinds of solutions for hepatitis C. So these are surveys of persons who have hepatitis C or who are at risk of hepatitis C. And basically the question is, would you be interested in taking an injection? Would you be interested in taking an implant? Would you be interested in an alternative to taking pills? Or would you just say, no, I want these pills? So that's the kind of patient interest surveys that have been done. And whether we're asking persons living with hepatitis C or at risk of hepatitis C, or importantly, policymakers like ministries of health in the countries where we might target these new innovations, there's high interest and high acceptability for these kinds of solutions. So up to over a third of individuals would actually prefer an injection, shown here in the orange, to pills, shown in the blue. And far more would cite that as their most preferred way of being cured compared to those who might want an implant, for example. And then policymakers are very interested in these solutions as long as, of course, they're not more expensive than what they're currently doing. Okay, so the interest is down to the fact that these might overcome stigma. They might be simpler to take, and hey, just get it over with. not have, everyone that has to take pills for some condition knows it can be an annoying part of your day. So the group at Liverpool have innovated, have adapted their method of nanoformulation of emulsion spray drying to be able to take lenacapavir and pibrentosphere and take these two compounds and basically reformulate them in a way that creates small particles that are stable, that can be reconstituted and injected into the muscle and achieve levels in the blood of animals that is above the target concentration of pibrentosphere and lenacapavir that is achieved based on oral dosing in humans. So in early animal studies, there's been success with not only the chemistry, not only formulating these compounds, but also in their being achieving the hoped for PK in animals. And very importantly, to that issue of the what do you get in the liver versus what happens with pills question, achieving the levels in the liver tissue of these animals that is comparable or better than the levels achieved with oral. So this is the sort of exciting innovation that might provide a new tool, a new way of solving the population problem of hepatitis C and tackling the 50 million some persons who already have therapy and are not being treated by the current innovations. So when I ask the question, when I'm answering the question of what's next for hepatitis C, there will be some medicines that likely will be approved by EMA and FDA and endorsed by WHO for alternatives to add to those that we currently have that will be pills that will be taken for 8 to 12 weeks and cure hepatitis C in those that have access to them. So that's what's next. That's what's most likely. In addition, and what's really needed are for solutions for people to come up with sort of, I don't know the right way to put this yet, but sort of to solve the diffusion problem and to come up with the resources and innovations that fix the problems that we have currently with reaching the last 50 million people. We have had amazing success, and there's countries like Egypt where millions of people have been tested and cured for hepatitis C, and where there's already been elimination achieved. But for most of the world, we're not even close, and there's no high expectation that we're going to be able to eliminate hepatitis C. Certainly not by 2030, as the original WHO projection was set. So some exciting things that have been done, exciting accomplishments, but still some pretty vexing problems ahead. And thank you very much for your attention. I do want to just recognize, I showed limited data, but I showed data from these groups from the Unitaid-funded longevity project led by Andrew Owen and the surveys. And then I showed some work done funded by the US NIH and led by Drs. Mehta and Sunil Solomon. And then, of course, I showed some of the data from WHO for their hepatitis group. So thanks very much for your attention.